Thank you so much. It is exactly 27 minutes past the hour. We thank you for staying with TV47 Daily Report. Now, my colleague Ann Odida had an exclusive interview with Deborah Mlongo Barasa. She is the Cabinet Secretary for Health on a wide range of issues. Please take a look at that interview as we continue to monitor your feedback.
Karibu sana Waziri to TV47. How are you doing?
Fine, thank you. And how are you?
I'm doing great.
Awesome.
So we're very happy to be here, first of all, to talk about matters health. And we just want to get to know you more. Really, we just talk about Deborah Mlongo, Health Cabinet Secretary. But maybe you can start us off with telling us your journey from being a practicing physician into now transitioning to the CS for health.
All right. So my journey began, again, as a practicing physician. I finished school in 2006, proceeded into internship, and then later on now, that's my medical school, and then later on went into practice. And my career at first was dedicated into clinical practice or clinical care, research and training in both the public and the private healthcare facilities. So I've again worked with multiple faith-based organizations at that time, and my experience grew, but ultimately I transitioned into leadership roles. That is again with various NGOs, including the World Health Organization, and I was more involved in the health system strengthening, policy development, public health initiatives, so in preparedness, readiness and response of various outbreaks like the COVID-19, Ebola, cholera and the mpox. And then being appointed as the Cabinet Secretary for Health, again I was called to serve the country, and I was really privileged from my vast experience and seeing the critical role of universal health coverage, which is affordable, accessible, quality care which is equitable to all. So seeing the various needs from the needy, the vulnerable in the community, those that are not informed, suffering from catastrophic illnesses and catastrophic expenditures, I was really privileged to come and address the systematic problems that affect our health system.
Now, your journey into internal medicine, you've mentioned that as well. So how has it shaped your approach in health policy?
Yes. So previously, internal medicine, it's really focused on one patient, and so it's a patient-centered approach. But now, seeing the need, with my clinical expertise, I realized that it's really beyond one patient. So there's the people-centric approach. There's the evidence-based medicine that we accrue over time. They are the best practices, lessons learned, centers of excellence across the globe that you pick through. So my career has grown from just focusing on the patient into a people-centric approach, into an evidence-based, decision-making approach, a data-driven approach to healthcare and health system strengthening, and again, interactions and networking with various partners in matters resource mobilization, in matters best practices with various ministers and technical experts across the globe. So it has really grown my way of thinking into health policies and health system strengthening, even as we move forward.
Waziri, are you actively practicing medicine?
No, currently I'm not.
So what is the motivation behind now coming into public service and taking up policy-making decisions?
Yeah, it is the exposure to the clinical practice, the challenges that we have been able to see patients going through, the people of Kenya, and again engaging with the community. At one time in my life when I was working with faith-based organization, I was able to engage with the communities and really understand that health is beyond a head to toe, it's beyond a cellular level. It is really, there's a systemic illness, there's a global illness, there's a continental illness, and there's a country illness in matters health system. And so this health system illness needs to be addressed. We need to cure it. And this is through strengthening, and this is through one of the critical ways is universal health coverage. In Kenya, it's Taifa care.
Yes. You've mentioned, I want to take you back. You say that you're not actively practicing medicine, but would you go back to medicine?
Absolutely. Absolutely, I would love to go back later on. Yes.
So the Ministry of Health is arguably one of the most challenging and contested ministries in the country. So 5 months later, how is it so far for you?
Yes. Yeah. So the 5 months have been intense, really, but incredibly rewarding, you know, from that background of seeing the vulnerable and needy and having 3 critical things that can improve the momentum, that can catapult health into a different level. What are they? First, we have strong political will from the highest office, you know, leading the process of universal health coverage. Again, we have the legal reforms that are now, you know, the bills have been passed into law. And we have the resources again to support us. So, you know, having these 3 in the country really is a good time for us to implement universal health coverage. So we are really privileged to have that. And so seeing from my vast experience, for me, it's a critical time. Yes, there's immense responsibility, UHC implementation. We have MPOX, doctors are on strike currently. But looking at the vision ultimately that every Kenyan can access the very same services. The health workers, at times, we could not. I can say that as a health worker, as a medical student, you cannot access the very services that you're offering the patients. Then we have the needy and the vulnerable who are being sent. When I say vulnerable, I'm talking about maybe person in Mlongo who falls from 2nd floor. He earns maybe 500 shillings per day. And while he's building a house, he falls. And he gets a fracture and he's told now, mzee, lazima utafute pesa. But he cannot afford that. So he's vulnerable. He wants his legs working. But because the health system is crooked, he's left on a stretcher, you know, or in the hospital for very many months. And so when you look at the vulnerable, the ones who are in need of these, you know, healthcare services, but they cannot because they cannot afford. And that is the daily, you know, exposure of many of the healthcare workers. So when we look at that, then as a country, we need to look at a sustainable solutions and support for them. And equally, I always remember the 3 things I've seen in, you know, in Kenya, and not just in Kenya, in Africa and across the globe. First of all, the population is rising. Infections are rising also. So we have high infections, we have re-emerging infections like COVID-19, cholera. Secondly, we have a high, the budget when it comes to health finance is really rising at county, at national level. Then again, we have the tight fiscal space, and you saw even with the Gen Z demonstration. Again, we have been over-dependent on donors for so many years. HIV, we've been over-dependent for 40 years, you see.
Are we addressing that? Are we addressing our over-dependence?
Now we need, now that is why, as a country, we need to come up with sustainable solutions, health financing solutions that are sustainable.
Are we on the right track in achieving that?
Absolutely, we are on the right track, and the right track is UHC. And the right track is having a health financing system where we have contributions. And I know the word mandatory is not palatable to all of us, but when we are all contributing into one pot, the rich, the poor, the young, the old, the healthy, the sick, and even those that are needy and vulnerable can access the very same health care. I believe that that is the way to go, so that we are not caught off guard. You remember with COVID-19, we were caught off guard, you see? Because now the health system was not resilient. And so where were we to place the patients? We needed, consumables like protective equipments like masks, etc. We needed vaccines. And you see, for those countries that we were dependent on, they took their populations or their citizens as first priority, you see. So what can we do as Kenya to ensure that there is a health financing system that is sustainable despite the tight fiscal space, despite emerging, re-emerging infections or diseases, so that we have resilient health systems and we are self-reliant as a ministry.
All right, amazing, Waziri. You've also mentioned the doctor strike, and I'm glad you have. These doctors, once they mention that you have never talked to them, Waziri, they say that you are one of them, yet you have never gone or called them rather to just have a conversation with them. How do you intend on addressing that?
No, we are addressing it. And, I always say one thing. As a young lady, as a young lady, you always think of, yourself and everything. But as a mother, you have a different responsibility. You have children, and you need to treat them equitably. So as an intern, it was all about internship and being a doctor. But the responsibility as a cabinet secretary calls upon me to support the human resource for health. Okay, so the doctors, the nurses, the clinical officers, nutritionists, physiotherapists, and the like. And so my approach is human resource for health. Now, we have been engaging the doctors extensively. We've been engaging the unionists. We've been having various meetings with the doctors, various WhatsApp groups, even the doctors in private practice, public practice, everywhere. And we are, again, expanding our engagement. I've engaged with the clinical officers, I've engaged with the nurses. I'm really calling upon them as the human resource for health. They are the people on the ground. They are the ones who serve the patients. They know the needs that this system works. And they are the ones who are seeing that Kenyans are needy. They are the ones who are seeing that they themselves as health workers, they cannot access some of these services, like a cesarean section in private hospitals. So how do we improve? And so we are extensively engaging the various human resource for health to ensure that they are on board, we are collaborating, we are working together to serve the people of Kenya.
Amazing, amazing. Now, when you say that you are engaging them, I don't know if they're lying if they say that you are not, they're not being engaged by you, but also when they come here at your gate to chant, if you allow me to quote, Mlongo must go, how does that make you feel?
For me, I always say what I'm coming to give is a passion for Kenyans. Is a passion that every Kenyan, no matter where you are, from which part of Kenya you are from, no matter whether you're vulnerable or needy, everyone must have access to quality and affordable care, health care. So that is a vision I've had from my practice as an intern until right now. So for me, until God tells me to leave, or His Excellency the President, I am committed to this noble cause, and I will work collaboratively. And you will see, at times these sentiments, maybe I did not reach out to one personal or individual doctor, but I can assure you that the discussions are ongoing. Medical universities, the teaching colleges for medicine, we have the Leaders Council, we have our elders in medical practice, we have the union leaders, we are meeting them, we have the private and public facilities, and among others. So probably this is an individual's sentiments, but yet again, I think we need to be focused and oriented on the ultimate goal, that Kenyans do have access to quality care. So if God gives me the chance, I'll be very obliged and happy to serve. Yes.
The 2017 CBA that they want the Ministry of Health to stick to,
yes.
Do you see it achievable?
Yes. Yes, it is, and we were able to meet His Excellency the President, and he has given his go-ahead for this cohort, and the money is actually being released as we speak. Equally, the arrears of doctors are being released as we speak. And so we are saying that, indeed, we are addressing their grievances and concerns, and will continue engaging further and looking at sustainable solutions so that we don't have the health workforce, the human resource for health, always going on strike. Because, ultimately it will cause death in our facilities. Yes. So we are engaging them, we are giving them a good share of the bargain, all right? And so we hope that even with the deliberations that are ongoing, that they will accept and take it up. And then again, now we can now focus on sustainable solutions for the health workers.
All right. Did you ever expect that things will turn out this way? A second threat, a strike in the healthcare sector in the country in the year 2024?
No, it wasn't actually, now that we're having SHA, yes. But, yeah, so, for us as doctors, when you're practicing, it's always you expect the best or pray for the best, but anticipate the worst.
Okay.
Always anticipate the worst. And so when you're bombarded by this mpox and also the doctor's strike, then again, we need to have that capacity to move forward and ensure that we are addressing the concerns as they come. Yes.
You are very passionate about serving these marginalized communities.
Yes.
And one time you mentioned you are passionate about people in the slums.
Yes.
Your first address as the Cabinet Secretary for Health. So how do you intend to ensure that there's equitable distribution of medical supplies in these marginalized communities and also just in the country in general?
Yes, absolutely. There's great disparity, and we recognize in matters healthcare in the slums and also in the rural areas, the hard-to-reach areas, where transport is a challenge, etc. And first of all, we look at data. Data-driven decisions. What are the contributors to, high infections and high deaths in this region? So what we are doing as a ministry, first of all, is to strengthen the primary care networks. By strengthening this, especially in the hard-to-reach areas, ensuring that they are equipped with essential medicines, the right human resource for health. They have, again, the equipments under the NESP. So we are mapping out, as I said, it's data-driven. So we are mapping out to identify what are the gaps in the rural areas, in the slum areas, the marginalized areas, and how do we again plug in resources to improve this. And that is through, again, the financial improvement fund plan, and also through the NESP project. We'll be bringing equipment, we'll be again bringing medical supplies to improve it. And additional to that is the community health promoters. We have more than 107,000 community health promoters spread across Africa. Across Kenya, sorry.
Yeah.
And so we are utilizing them, first of all, to strengthen prevention, promotion, management, rehabilitative care at community level, identifying the sick and bringing them to the facilities, among other activities. So there is a lot, and we are looking at data-driven decision-making, even as we support the various components to ensure that there is equity and inclusivity when it comes to healthcare management.
All right, now the Kenya Biovax Institute is committed to producing vaccines locally.
Yes.
How is the progress so far with this initiative?
We are progressing steadily, and it really remains a key part of our strategy to ensure that vaccine security, we have vaccine security, and we have reduced reliance on, outside markets or imports when it comes to vaccine. And so we are finalizing on the necessary infrastructures, including a production partnership with the global vaccine production, and also working together with vaccine manufacturers to ensure that we are improving this. So there's a lot going on. We've been having a bit of challenges, navigating through the regulatory processes, among others. But the ultimate goal is to have our own vaccine production. And COVID-19 really showed us, we were really dependent on imports from outside to vaccinate our people, you see. And so even with the dwindling funds, Gavi again, the vaccines, the resources gradually reducing, Kenya needs to think about vaccine production, local production of that for our children, and also for emerging and re-emerging infectious diseases. So we are working collaboratively, we're working close with the Biovax team to ensure that this is brought to fruition.
Amazing. So what is the ministry doing to ensure that we are prepared in terms of combating or just being prepared when a pandemic strikes?
Yes, we need to, and really it's a multifaceted approach that we are having in terms of pandemic preparedness. And again, we are looking at readiness and response frameworks when it comes to various outbreaks. And so we're working on the National Action Plan for Public Health Security. We are meeting with various partners to support us come up with the comprehensive plans. We have also enhanced our disease surveillance. Again, we're looking at investment in vaccines, therapeutics, and emergency stockpiles. We are beefing our laboratory capacity to ensure that we're able to diagnose these diseases early, and then training of health workers, and again our digital health system, so that we're able to promptly identify any infections that may occur within the facilities, and ultimately we can have a rapid response team to support that. So a lot is going on in matters of, yes.
So bioterrorism and biosecurity has been mentioned in regional discussions. Yes. What are we doing as a country to ensure that we are protected regionally in terms of pandemics in the region?
Yeah, so first of all, Kenya is actually leading in the East Africa, yeah, in matters of to counter bioterrorism and biosecurity. And so we are again working together to improve the lab capacity, the surveillance, and then again the cross-border collaboration with the East Africa and the African region. We have partners like WHO, Africa, CDC, again who help with the cross-border collaboration, and then also help us in building the capacity of our country. So a lot is going on. We've been able to put down early warning systems and emergency preparedness protocols to ensure that we are ready in matters of response to any outbreak.
All right, now I want to take you back to the health resource. Kirinyaga County, for instance, the governor mentioned that they're introducing incentives to ensure that their top talents in the healthcare sector are retained. Now, also considering that health is a devolved unit, how is the ministry planning on ensuring that the healthcare workforce generally, the top talents are retained?
Yes, that is brilliant. We really need to ensure that our top talents are retained. And part of it is, again, through having a career progression, having training, having specialized centers of excellence across the country. We have various programs that are in place, such as the for obstetrics and gynecology, surgery, internal medicine, etc., that will be able to capacitate and again improve quality care within the facility. So as the doctors are training, again, it equally improves the quality of care. And we are also looking at improving the health working conditions, ensuring that there's career growth among health workers. Yes.
How about in the underserved areas? How do you plan on retaining the health workforce there?
Yes, in the underserved areas, we incentivize them. So in housing matters, in getting extra costs as they stay there, in ensuring that they are prioritized when it comes to specialized courses, right? And again, we are thinking about ensuring equitable distribution of level 5, level 6, capacitating them so that they can take up specialized training. You don't need to come from Wajir to be trained in Nairobi. So how do we ensure that we have the best specialists in that area? And again, we have human resource who are coming to specialize in Wajir and other areas, like say Turkana. So it's incentivizing them, and one of the best ways to incentivize doctors is ensuring that they have some kind of a master's program or have some kind of fellowship within these hard-to-reach areas. So you serve the community with specialized skill as they become specialists, and now that cycle continues. So those are interventions that we are looking into as we look at the HRH policy, so that we are serving the underserved community as well.
You've mentioned a very good example that has taken me back to a conversation I was having with one of the interns during the last protest down here, and he was saying he's from Meru, and he has been stationed in Wajir with no pay for 3 months. How is that? How would you address that?
I've been an intern before. I understand. I understand. For us, then they're like us. We used to be paid 35,000 at that time, and you can imagine the hardship. And we used to stay even for 6 months. And I believe the government has done a lot. They acknowledge the government has done a lot. From getting from 35,000 to 206,000, I mean, it's amazing. But yet again, how do we ensure that we have good working environments, good infrastructure, good career paths, not only for doctors, but for the human resource for health. And that is part of the HRH policy, the interns policy we are working on. And again, when we look at what they gave us in the CBA agreement, we have to implement, yes. And then again, so we are engaging them. We are engaging them to see what are the sustainable solutions. How do we grow, not just for the doctors, but the human resource for health? How do we build their capacity? How do we address the mental health concerns, among other concerns that they may be having? So engagement discussions are going on with their leads to address this.
There's also a plan by the ministry to digitize healthcare. So how do you plan on leveraging the technology and AI to enhance service delivery in the country?
Yes, that's a brilliant question. We are really looking at 100% digitization of the healthcare system. That's the only way we can have data-driven decision making. That is the only way we can actually see what is going on across the country. We have in the system, we have GIS, we are able to geomap where our primary healthcare facilities are right from level 2 up to level 6. And so looking at matters, accessibility, and then mapping that out and then looking at the population at that place, even as we build the primary care networks and the referral mechanism. Yet again, we are looking at issues of supply chain, issues of the medication, the cost of medication, so that we are not getting a raw deal because some medications are high. And again, using the same system for health surveillance and again for training. So it is becoming, AI is incorporated in it, and gradually it's becoming smarter, even to identify outliers when it comes to, the claims management. At times we have extreme outliers and we can tell this facility is demanding for more money, and then we can zoom in and see if there are any technical challenges or we are having leakage of resources because of that. Yes.
So let's talk about one of the most debated topics in the country, and that is the Social Health Authority, SHA.
Yes.
I know you've addressed it on very numerous occasions, but do you think the country is really aware, everyone in the country is really aware and understands what SHA is all about?
Okay, yes. First of all, we've made great progress. From when we started, now we are less than 100 days old. I think there's great progress, but there's a lot more that needs to be done, especially at community level. It matters community sensitization, outreaches, using the local leaders and the community health promoters and the GAOs. And there are, best practices that we can borrow from countries. One of the countries I visited told me that, yes, when we started UHC, at first there was a lot of resistance. This is because, you're cutting someone's salary. So there's grievances related to that. But as the system continued to grow and continued to serve the people, as they met in the barazas, as they met in the, the Jumba Kumi meetings, etc., then they were able to hear some good testimonials and see the benefit of this program. So that is what we are lacking. There's a lot of negativity, and I understand the grievances based on the, the cutting of one's salary. But as time grows, what we want to believe is there'll be more testimonials. I'll give you an example. We've had more than 500,000 Kenyans that have been able to access health services through SHA. But very few have come out openly. Then we have a few critical cases here and there that again have had some grievances. But that is augmented. The 3 cases are louder than the 500,000 that have really benefited from it. While we are looking at the critical care package, because we understand that it had some challenges, and we are looking into improving the benefit package, the optical, the dental, among others, yeah. But there is again some positive stories that have come out. Over 500,000 Kenyans have been served, and I think there is around 6 billion of services from the claims, if I'm not wrong. So those are the stories that we need to hear, and maybe they could the stories could reflect on the TV or on media. But when we strengthen our community programs and we hear that my neighbor delivered under SHA, my neighbor underwent operation under SHA, and so on, those testimonies within the community are really what will bring faith. And for us, again, we need to address the trust issues as a Ministry of Health. There were great concerns about NHIF. Now they're saying the SHA is mandatory for everyone. Now maybe this would be, even worse. So that would call upon us, first of all, to engage. And again, transparency and visibility. So our reports, we are sharing them routinely with the various healthcare providers, the roofer, etc., to show them that actually we have disbursed funds of this proportion to these facilities. Even at county level, we are telling them, your county has been able to receive this amount of money. So one has received maybe 500 million, but the other one is receiving maybe 5 million. And so it calls upon the one receiving less money to improve the health services. First, to register patients under SHA, or people, the population under SHA. Secondly, to offer health services under SHA. That way they will send claims and money will come back to their facility. And gradually we'll be able to improve our health system and the capacity within the facility level.
Don't you think that the mistrust in SHA is stemming from communities not really well versed with the primary objectives of SHA?
Absolutely.
And how do you intend on addressing that with them?
Yes, as I said, it's not a one-day event. It is gradual, and it is not even for a year. Community engagement is routine. Yeah. So with the testimonials or the testimonies, we will have greater community engagement. With the challenges, then they will be escalated up, and we will address them as a ministry and as SHA, so that we gradually improve the benefit package. But now engaging more with the community, as I said, through community outreaches, through community sensitization, etc., we can be able to improve it. And this is really an ongoing process, not just a one-off. Yes.
So for the benefit of our viewer, Waziri, who is just who is watching you right now, how does SHA differ from other healthcare financing, the NHIF, the ones that we've had? Tell us about that.
So what SHA looks into, it is inspired to address the inefficiencies in healthcare financing, so especially under NHIF. So when you look at NHIF, it had a fragmented approach. We had multiple schemes within it, and so that one further depleted the funds, the contribution of members, and you would see that there's a preponderance to a few people in the community, like the civil servants, who got a better deal compared to the normal mwananchi. So what SHA looks into is to address the inefficiencies, have what we ideally is to have a mandatory contribution, so that everyone is contributing to one pot. The rich, the poor, the healthy, the sick, everyone, and even those that are vulnerable, the old, the young, the needy, are able to access the very same health care. So it encompasses everyone. And when you look even at the statistics, NHIF only had 9 million people on board. But now we are just less than 100 days and we have almost clocking 17 million. We're at 16.6 million Kenyans. So you can see that there's expansion in matters numbers, the population numbers, expansion in geographical expansion, so the hard to reach areas. We are also addressing the needy, the vulnerable, expansion in the facilities that we are onboarding, and then the benefit package. It may not be clear right now, but as the years go, we will gradually improve the benefit package to have a better and a comprehensive package. But you remember, it's all about the contributions. So again, it calls upon us as a ministry to ensure that Kenyans are registered and are contributing, and we are reaching out to the informal and the formal sectors to again support in contributions. Yes.
So Waziri, you can also break it down for us. This Taifa care, this SHA, this SHIF. You know, Kenyans are a bit confused.
Yes.
Taifa care just came last month.
Yes.
So maybe you can tell us about that too.
Yes. Now, social health insurance is the health insurance that is you're contributing a certain amount, that is 2.75% of your earnings. Okay. Now, under SHA is the social health insurance. In addition to that, there are those ones that are contributed by Treasury or the Exchequer or the government. That is the primary health care fund, the emergency chronic and critical illness funds. Those ones are contributed by the government. But yet again, we need to be visionary. And what we are saying is if ultimately we could also be able to be self-sufficient as SHA, so that we are the PHC, the primary health care funds, and the ECCIF is again being contributed. It would be great. It would be wonderful. That way we are not over-dependent on Treasury, because even the funds you can see are they were reduced a bit when it comes to Treasury, and that is how we are getting grievances from the community. So SHA encompasses the three funds. It covers the funds from the primary health care fund. It covers emergency, chronic, and critical illness funds, and social health insurance funds with the contribution, the 2.75 contribution. Now, Taifa Care is universal health coverage. So, in a system point of view, we are coming from the community health promoters to the primary health care and the different levels. In matters pillars, we are also looking at the human resource for health. We are looking at the health products and technology, the digital health system, and the social health insurance. And for the digital health technology, what we are saying is this is an enabling environment. It is efficient and effective. It leads to transparency and visibility. It fights corruption, and it causes data-driven decisions, because we'll be able to highlight and say, there are no medicines here, we need to shunt. Why aren't patients being seen in this facility? We start engaging the county and facility level. Why are people being referred for a certain service, maybe like X-ray, etc.? Now we intervene. So gradually we will be improving the health system as we move forward.
Mm-hmm. So there's a perception that SHA cover for civil servants and that of those in private sector are different. Is that so?
Yes, they have their own medical scheme. Yes.
Why is that so?
Yes, and really looking at the vision behind it. I totally agree. We need to make UHC work such that, the mentality in Kenya is private facilities are better than public. Private facilities are more equipped. You'll find medicine, but now we are countering that by bringing balance, and through the FIF Act, we'll have improved improvement in the public facility in terms of capacity. And so we hope that ultimately people will be able to trust the public facilities. When you go out in some countries, they rarely visit the private facilities, because they know in public you have the most skilled and experienced healthcare workers, because they see everything and anything. You have the medications on ground, you have equipment, etc. So ultimately, I believe that we need to bring it up to that level. But as employers, and our employees are requesting for that, we are employees to the government. If the employees are requesting that to the government, then I think it's the obligation of the government. But gradually, if they see the beauty of it, then they will embrace it.
Waziri, 5 months later, how would you rate yourself?
Yes, it's been an uphill task. I totally agree. I came in when the plane had was just leaving the runway. There was great turbulence, but now I believe that we are up in the sky above the clouds, and there's some stability. And ultimately, we are moving towards the destiny, which is Vision 2030.
From a scale of 0 to 10, Waziri, how would you rate Dr. Deborah Baraza Mlongo?
Yes, and so for me, I am vision-oriented. I am focused to implementing successful UHC. So even with the challenges that we are having right now, that is the ultimate vision. And it also brings for us to work as a team, to collaborate as the ministry, national, county, partners, community, etc., to work towards this, right? So we have implemented UHC. Yes, we have done something in terms of communication, but we need to yet again do more. We need to again engage more. We need again to improve the benefit package. But remember, this is less than 100 days old. We have 2 to 3 years to work on a very steady UHC and become a best practice. And so with that, I'd say we progress.
Mm-hmm. So how do you envision the country's healthcare sector, because as we wind up?
I believe that by the vision is Vision 2030. The critical thing is affordable, accessible, quality care, which is equitable and inclusive to all, that we are leaving no one behind. And so that is what we hope to achieve after, yes.
All right. That's it. Thank you so much, Waziri, for making time for us. It's an honor for us to be here today, and we've gotten to know you more, at least, and also to understand SHA and what you stand for as the Cabinet Secretary for Health. Asante sana, and have a good day.
Thank you. Thank you also for having me. Thank you.